So a brief introduction. As we're all aware, infection and inflammation can present a major diagnostic challenge for clinicians, and as we've heard about many areas today, diagnosis and precise delineation of the pathology is really critical, particularly in certain scenarios. And whilst cross-sectional imaging provides very high quality anatomical detail, as we've heard from other talks, the structural abnormalities underlying infectious processes can be very non-specific. So the combination of functional imaging really brings things forward. So, as most of you will be aware, there are a number of different tracers that have been used over the past 20 or 30 years, particularly Galium 67 Scintigraphy, and more recently labelled white cell scintigraphy using either Indium or Technetium. There are a number of other smaller prints, things like Leukocyte, etc., which I won't go into any detail about. And then I'll briefly talk about bone scintigraphy as well in the context of infection. As we've heard frequently throughout the day, the main criticism of planar imaging is the poor spatial resolution and the low specificity, and really adding in CT brings things together and improves the quality of the study overall. So one of the first major publications that was in the Journal of Nuclear Medicine back in 2006 was by Israel's group from Israel, and they looked at the value of SPECT-CT in a group of patients who were undergoing investigation either with Gallium or Indian-labelled white cell scintigraphy, and they had quite a sizable cohort of patients, 82 patients, and again, not a surprise, but in nearly half of the patients, the use of SPECT-CT improved diagnosis and localization. And splitting it into the two halves, in the Gallium group, it was contributory in about a third of patients, particularly in those with suspected osteomyelitis, and to a lesser extent in those with soft tissue infection or fever of unknown origin. Looking at the white cell group, it had a particular use in about 2/3 of patients with suspected vascular graft infection and about half of the patients with suspected osteomyelitis. So the 5 areas I'm going to cover really are the use of SPECT-CT in patients with fever of unknown origin, suspected bone or soft tissue infection, suspected vascular graft infection, assessment of the diabetic foot, which we haven't heard about today. I thought we might have done, so I won't be boring you with the same things, and then just to finally finish off some late-breaking applications. So FUO really is defined as a temperature of greater than 38.3 degrees C for more than 3 weeks, and as you are probably aware, in about a third of patients the diagnosis will be an occult infection, and the other 2/3 that's split between occult malignancy and inflammatory disorders of various sources. And here's an example from the early days with a hybrid camera in our department. This was a Friday afternoon scan. A patient from a DGH had been referred centrally with a fever of unknown origin. We didn't have any prior imaging. This was the planar image. You can see there's focal uptake there in the left side of the pelvis. On the low-dose SPECT-CT, you can see that the things are looking pretty unhappy, and there's this focus uptake which appears to be localizing to the sigmoid colon, but more importantly there is free gas within the anterior abdomen, and there's free fluid within the belly which you clearly wouldn't pick up without the benefit of the CT. And this patient actually was admitted to our hospital, and they'd got perforated diverticulitis. Quite how that hadn't been picked up beforehand, I don't know, but it illustrates nicely the added value of CT in that setting. This is another patient who'd been languishing on one of the care of the elderly wards with a fever, and they were scratching their heads, hadn't really got to the bottom of it. And we did a bone scan, and you can clearly see on the bone scan that there are really quite abnormal foci of uptake, both related to the right shoulder and within the spine. And doing SPECT-CT, we could see that in the spine there was quite a lot of soft tissue around in the paravertebral region, and similarly around the shoulder, and this was multifocal infection. And you can just see on the views there. Moving on to suspected bone or soft tissue infection, it can be particularly useful because sometimes these patients, it's critical whether the infection is within the bone or the adjacent soft tissues. And by using SPECT-CT, you can much more accurately define exactly where it is. The typical example of where it can be very difficult is in a patient that has had previous trauma and they've got a plain film which shows an old fracture which has become symptomatic, and they've got a bit of a temperature, and you're not sure whether there's infection that's related to the fracture in the bone or whether it's adjacent to the soft tissues. And so this is the Rome group, who again have been very prominent in the SPECT-CT literature, and they published back in JNM in 2006 the use of technetium-labelled white cells, particularly for looking for bone infection. They also looked at prosthetic joint infection. And in their series, they had 15 patients with suspected osteomyelitis and 13 with possible infected prosthetic joints. And you won't be surprised to hear that SPECT-CT correctly characterised and localised uptake in all of the patients with osteomyelitis and was able to very clearly discriminate between soft tissue and bone infection. And as a consequence, it had an impact on a major percentage of patients, as we've heard frequently today. And the particular benefit was in patients with osteomyelitis, where they had abnormal bones following trauma. So this is an example case. It's a patient who'd had previous trauma, and they had represented with broken skin and pain, and there was a strong suspicion of infection. This was the plain film. You can see that there's an old fracture there, which is non-united. And first off, they had a 3-phase bone scan, which is clearly abnormal. And on SPECT-CT, it doesn't take a genius to see that the uptake is localising to that fracture site, but we don't know whether that's infection or just a malunited fracture. So they went on to have a white cell scan, and you can see on the white cell scan that that fracture site is completely photopenic, whereas there is focal uptake within the soft tissues anteriorly. So the combination of the two and the addition of the SPECT-CT has allowed us to come to a very clear and concise diagnosis of bony non-union with soft tissue infection, which has a major bearing on how they treat that patient. Here's another example. Gopi kindly lent me this image of a patient who had a fever and pain in the foot, and you can see the combination of the high-resolution CT and the SPECT shows this osteomyelitis with bone destruction within the calcaneum. There's another example, again from Guy's and St Thomas's, where the patient had presented with different patients, similar symptoms, but on this occasion you can see that the area of activity is clearly localised to the soft tissues as opposed to the bone, and this was soft tissue infection. And yet another case, again, a patient with ankle pain, and this was clearly localised to the soft tissues overlying the lateral malleolus, but not involving the bone. And another patient who, on this occasion, presented with arm pain and quite a lot of swelling, and it was not clear whether there was underlying bone involvement, but on the SPECT-CT images you can clearly see that there is extensive tracer activity within the soft tissues, but no involvement of the underlying humerus. This is one of our cases, and it was a patient who's quite a complicated case who basically been paraplegic for a number of years following a road traffic accident, and he had ulcers within the right groin and the left buttock, and I was concerned about osteomyelitis underlying that, and cross-sectional imaging had been difficult to interpret, and using the SPECT-CT you can clearly see that there is soft tissue infection within the perineal region, but there's also ischial and sacral osteomyelitis. So the combination of structure and function really gives you the full picture and allows you to take this case forward with confidence. Moving on to vascular, and nowadays with the use of endovascular stent grafting, it's becoming more frequent for us to be asked to use functional imaging to assess these grafts in patients that come in with pain or raised inflammatory markers. And early and accurate diagnosis is really critical because it can be life-threatening for obvious reasons. And white cell scintigraphy has been used to assess this. It, as we heard from John Buscombe earlier, is being heavily threatened by the use of PET-CT, possibly as the superior technique, but there is a reasonable body of evidence for using white cell scintigraphy, and it very much depends on your local departmental capabilities. So in our experience, we found that white cell scintigraphy is significantly augmented by the use of SPECT-CT. This is a case of a patient that had a femoral graft, and they come in with a painful groin and they've got raised inflammatory markers. The planar images show subtly increased uptake in the left groin, but it's pretty subtle. When you use the SPECT-CT, you can see more obvious focal uptake related to that groin. Here's a more recent case where it was a patient that had an aorto to left femoral graft and had come in with an abscess in the groin, and there was considerable concern about graft infection, and you can see on the hybrid imaging there's very extensive uptake related to that vascular graft, and this patient had to go for emergency surgery. There was a recent paper in Nuclear Medicine Communications which looked at patients having technetium-labelled white blood cell scintigraphy with SPECT-CT, and the neat part of this paper was they looked at using an objective interpretation criteria for evaluating whether they had graft infection or not, and they used background uptake, and they compared marrow and liver activity, and in their series what they found was that comparing it to the liver activity, if there was activity within the graft greater than the liver, then it was highly specific for infection. And a couple of examples from that paper. This isn't the same case as ours, but someone else with a groin graft which is clearly infected. This is a different patient who had a large thoracic aortic aneurysm and had a stent graft and came in with raised inflammatory markers. And you can see on those multiplanar reconstructions that there's no significant uptake when you compare it to the liver, which you can see on those images. So it has a very high negative predictive value in that particular case. The other area where I think SPECT-CT has a considerable role is in the assessment of the diabetic foot, which can be a difficult problem, and basically you get rapidly progressive neuropathic arthropathy in these patients, and they're at risk of osteomyelitis. And the treatment vastly differs between osteomyelitis and just adjacent soft tissue infection. And in most cases, they start with soft tissue infection because of a breach in the skin, and then they develop osteomyelitis as a consequence of that. And it can be very difficult just using planar imaging and SPECT to know whether you've got one or both. And so there was a nice paper, again by the Rome group, Shalassi et al. From Journal of Nuclear Medicine, looking at SPECT-CT with white blood cell labelled scintigraphy, and they looked at the value over and above planar imaging and SPECT, and in over 50% it changed the interpretation of the study. It was able to confidently exclude osteomyelitis in 6 cases, and it revealed a cold bone infection in 1 case and a combination of the 2 in 3 patients. So here's an example of a patient who basically presented with a painful Charcot joint, and on the SPECT-CT you can clearly see that that focus of uptake is within the soft tissues of the sole of the foot and doesn't involve the bones. We don't have the eloquence of the multi-slice CT, but you don't really need it for this particular setting. And here's another case using gallium this time rather than white blood cell, and in this case you can clearly see it's involving the bones of the midfoot, and this patient went to have surgery to eradicate that. Just closing up now, very recently there have been a couple of publications. First off, looking at the role of SPECT-CT with labelled white blood cells in evaluating patients who have left ventricular implant device infection. And this paper from J&M again, from a group from France, had looked at a series of patients who presented with suspected infection of these complex devices, and they found that SPECT-CT was really helpful. It found infection in an additional 2 patients compared to planar imaging, but the main benefit was that it provided additional relevant information about the exact location of the infection, and in particular about distant infected foci. And here's an example. You can see in this case there was seeding of infection in multiple different sites along the device wires as they came out through the subcutaneous tissues. And finally, one role where it might be very useful is in the evaluation of patients who've got complex anatomy. So this is a patient with polycystic disease of the liver and kidneys, who's presented with a fever, and there's a suspicion that there might be infection in the polycystic kidneys. And this white cell study, which was kindly donated from the guys at the Royal Free, clearly shows the focus of uptake within the upper pole of the left kidney, which was due to infection. So hopefully I've speeded through things, but not lost things in translation. I think I've shown that SPECT-CT can have a complementary role in the investigation of selected patients with suspected infection because of its ability to allow more accurate localization and increasing the specificity, which in itself helps with patient management. And I'd just like to thank again Patrick Fielding from University Hospital Wales, GOPI, and Dr. Neville Kissel from the Royal Free for donating some images for the talk. Any questions?